my preparation for becoming a doctor in 80s. Can I have some decorum, please? Suno yaar. So diuretics were right on the top on the recommendation list of JNC, Joint National Commission. Up to JNC 6, there were recommendations of using either beta blockers or diuretics to start with. It's only when the whole scenario was invaded by ARBs and ACE inhibitors and the newer calcium channel blockers that we started, with, as we call it, customized treatment for blood pressure. And after the reinvention, rediscovery and relaunching, repackaging of chlorothiazide, that the interest in diuretics rose again, and now diuretics are again assuming the role that they were supposed to be fulfilling in the initial days. And one of the diuretics that we are going to discuss today is hydrochlorothiazide. Dr. Sengupta is an eminent physician, diabetologist. He is MD from SMS. He is an alumnus of UCMS and he is FRCP. He was chairman, Delhi chapter RSSDI. He is very active in RSSDI, in the whole thing, and he is instrumental in making our forum visible to the bigwigs in RSSDI. Everyone talks about our forum, we had Dr. Makkad, we felicitated him. Then Dr. Sengupta was instrumental in getting Dr. J.K. Sharma, who is also Karta Dharta of Innovative Physician Forum. So a lot of people know about our forum now, the kind of good work that you people are doing, we all are doing together. But as I always say, the most important thing, the bottom line is that you people decide to turn up every single Wednesday for last 20 years, and today for the 953rd time, ladies and gentlemen, we are again together consecutively, without interruption, without a single break in the last 20 years. Can you believe? Every single Wednesday. So it won't be too long before we celebrate our 1000th CME with cooperation from all of you, and we plan to have a conference when we have a 1000th CME. Dr. Sengupta will be speaking on hydrochlorothiazide, its values, where it's going to be useful, its place in the overall scheme of things, and in the recommendations that we have today. Over to Dr. Sengupta for his presentation. I request all of you to please welcome him with an applause. I also request all of you to be please kind to him in the question answer session and ask him soft questions, not hard questions, and shake hands at the end of the talk, otherwise he might pull out of the next talk.
So, thank you very much, Dr. Chauhan, for those kind words and setting the context so beautifully for the talk that is to follow. I mean, diuretics, we will be discussing that. But the better part of the whole story this evening is that Dr. Chauhan is the chairman today. And like my good old teacher, he has said that he promised me that he would be taking care of all the questions that are to follow. Yeah. So as has already been discussed, that diuretics had have had a sort of a roller coaster, right? Earlier they were taken as a very integral part of therapy. Then something happened because of the newer drugs getting introduced. But then again, with the JNC 7 coming into prominence with the recommendation of diuretics, primarily chlorothiazide, because it was easily available, the name at that time was hydrochlorothiazide. And there were seminal studies like the SHEP, systolic hypertension in an elderly person, the all-had study, which kind of reinforce the thought that diuretics should be given as first line. So let's see how the story unfolds, and along with that, as happens as the want of times that, many molecules in the same category come up. So earlier the concept was that of thiazide-type diuretics and thiazide, then it became thiazide-like diuretics. And the three prominent players in the scenario are chlorthalidone, hydrochlorothiazide, which Glenmark has very generously talked about today, and indapamide. So after the basic talk by the company is over, I would sunny the field a little and then take you through where exactly the evidence stands vis-a-vis the other two diuretics also. So as to reinforce your thoughts as to what you should be doing, listen to your patients, and what exactly we are looking at in terms of the clinical scenario. So, new evidence for diabetic-based treatment for hypertension. All the basic drums have been about chlorthalidone, but how do we place hydrochlorothiazide? Let's have a good look at that. So, and I will also be talking about the combination of hydrochlorothiazide with telmisartan and how this basically helps in the blood pressure control. So, giving you a preface initially about the basic introductions, the general things about hypertension, control, lack of control, etc. Going on to the molecules independently and in combination, then we take you through the areas of what we call as so-called discrepancies and what do we learn from that, and then finally summing it up. So, the importance of hydrochlorothiazide alone and in combination with telmisartan. Now we know that hypertension control rates are very low worldwide, and it's not purely an Asian or an Indian phenomenon. It cuts across the spectrum the world over. And the rule of halves is there, that half of the patients are diagnosed, half of them receive treatment, half of them reach therapeutic goals and and half of them basically continue with the therapy. This is the US NAIMS data, the National Institute which summarizes their stats. The blood pressure control rates are decreasing. So the control rates are decreasing over a period of time that you see from 2009 to 2020. It has been going down substantially from a figure of ostensibly 52.8% to 48.2%. And the figures would obviously be more horrendous in our country because we do not really document all the cases that we have. So suffice it to say, it would be much worse in our context, in our scenario. At the same time, the hypertension-related cardiovascular mortality is increasing. So not only is the control decreasing, but the cardiovascular mortality is also increasing across the spectrum. And if we see the hypertension control rate, what I was just alluding to just a minute ago, that out of the 100 hypertensive patients, barely 27.9% are aware, of which 14.5 are on treatment, and of which only a measly around 10% are under actual control. And this is a very sorry figure, but this is what the practical reality is. So poor adherence to hypertension treatment by patients and under-prescribing of hypertension drugs by clinicians. There is a huge amount of therapeutic inertia which is there. And these are the two major explanations for poor blood pressure control, not to talk about very low rates of detection and people remaining asymptomatically hypertensive and just being picked up incidentally. Now, among treated uncontrolled hypertensive patients, 44% were not taking all the anti-hypertensive medication as prescribed by their healthcare professional, and sadly enough, 17% were not taking any anti-hypertensive medication at all. So that's the level of, I would only call it ignorance which is there. And combining anti-hypertensive drug classes, mind you, we are talking about drug synergism, has been shown to be more than 5 times more effective for lowering blood pressure than doubling the dose of a single drug. So if you see across the spectrum, whether we are looking at thiazide, beta blockers, ACE inhibitors, calcium channel blockers, and all classes, if we are doubling the drug dosage, the level of control and the efficacy goes up minuscule compared to when you are adding a separate drug which has synergistic effect. Now this is the core drug treatment strategy, and this has been taken from the NICE guideline. Initial therapy, you're looking at a dual combination, preferably a single pill combination. Then add on the second drug, and then if you see resistant hypertension, you can add spironolactone or other alpha blockers or beta blockers. And then even in other cases, you will be looking at other drugs like minoxidil, hydrazine, etc. So you basically have a sequential therapy which should be customized as per the patient's needs. And all the major international guidelines agree on the solutions to uncontrolled hypertension, whether we are looking at all these several international organizations. Restoring diuretics to a primary place in choosing blood pressure treatment is an important start. You look at the ACCHA guidelines, they say that thiazide diuretics belong to the first line therapy and a fixed dose combination initially itself is recommended. So you can go slow with lower dosages and then gradually build up. So the synergism affects, helps to control things better. Likewise with the WHO guidelines, likewise with the ESH guidelines, and diuretics, what they said was diuretics are one of the most preferable classes of drugs at all stages, and a single pill FDC is probably a better thing to go through. Now looking at different guidelines, different numbers, different criteria, but two outcomes are there. All hypertension guidelines recommend initiating pharmacotherapy with single pill combinations, and diuretics seemingly play a critical role at all stages of hypertension management. Now why is it important? Because the evidence suggests the recommendation very strongly regarding the use of a single pill, and it should be more rigorously implemented because there is higher persistence to medication adherence under a single pill, and consequently there are less cardiovascular events, all-cause mortality, hospitalization, etc. But these are all sequential things. You constantly have to uptitrate and tailor things according to the clinical situation. Now look at the molecule of focus this evening. We are talking about hydrochlorothiazide, which has efficient blood pressure control, cardiovascular protection, and patient safety. So the usual dilemma which comes up is, and which has been there for a fairly long time and still not resolved totally, but I'll just take you through the semantics of description and whatever the evidence says. Hydrochlorothiazide versus chlorthalidone. Hydrochlorothiazide has at least equal benefits on cardiovascular outcomes and is postulated to have a better safety profile. So let's look at the latent hypertension sub-analysis in which hydrochlorothiazide and chlorthalidone were found to be comparable in terms of efficacy. If you see the odds ratio out here, they are more or less all along the line of unity. So what was basically the summary of it? Hydrochlorothiazide may provide at least equal cardiovascular protection in terms of reduced risk of cardiovascular mortality and ischemic stroke compared with chlorthalidone. Also, it was associated with reduced risk of potentially type 2 diabetes as well as metabolic imbalances, notably hyponatremia. Not to say that the other drug did not cause it, but the tendency for this was lesser. And I will be visiting this particular trial later during the course of the discussion. And this was a trial which showed that patients with chlorthalidone did not have a lower occurrence of MACE than patients who received hydrochlorothiazide, but had significantly higher hypokalemia, electrolyte imbalances, which often, basically forms a barrier to the persistence of therapy. Also in the same study, hydrochlorothiazide was associated with reduced risk of primary outcome events such as heart failure, hospitalization, or urgent coronary revascularization, or non-cancer related deaths. If you see for both the drugs, all the bars across all the spectrum of endpoints that were studied, they are more or less similar. So chlorthalidone use was associated with a higher risk of hypokalemia incidence and estimated GFR decline as compared with hydrochlorothiazide use, And you can see it across the spectrum of all the levels of EGFR that was calculated. The graph is not complete because it doesn't really show the exact amount of hypokalemia which was happening, but this was the summary. Hydrochlorothiazide potentially ages about chlorothalidone in the elderly with CKD because chlorothalidone had a potential risk factor for acute kidney injury and also the propensity towards electrolyte imbalances. And this was associated with low risk of cardiovascular events compared to CKD, such as MI, heart failure or atrial fibrillation in this particular trial. And I will be talking about this later also in my own slides. So guidelines provide a strong recommendations for the combination of diuretics with ARBs, and worldwide for strong scientific reasons, telmisartan, as we know, is the most widely used ARB. Now this was a comparison of the ARB based and controlled regimes with multiple significant worldwide trials. We had SCOPE with candesartan, IDNT with irbesartan, renal and losartan. And as you can see, in the line of unity, all of them favored the usage of ARB. We were looking at the metrics of stroke, CHD, heart failure, major CV events, cardiovascular death, as well as total mortality. Very significantly, when we see the duration of action of telmisartan, whether we are looking at the first 6 hours of dosing or the last 4 hours of dosing, the dip in both the systolic and the blood pressure and the diastolic blood pressure is almost equivalent, which means that the effect lasts practically right to the 24 hours. So technically, ideally, it's a 24-hour drug. In the seminal on-target study, which basically saw almost 40,000 plus patients, telmisartan was the only ARB which was found, which was FDA approved as an alternative to the ACE inhibitors for cardiovascular protection in high-risk events. So it has a long duration of action, full 24-hour effects, powerful blood pressure reduction, and the first and only ARB to be FDA approved for cardiovascular protection in patients at high risk of cardiovascular events, which was almost similar to ramipril in the HOPE study. And the HOPE study also, ramipril had a very small fall in the blood pressure, but what that showed was it translated into humongous cardiovascular benefits. Now let's look at the combination. This particular article, the seminal trial, the Search 2, telmisartan and hydrochlorothiazide increased smooth 24-hour blood pressure control in daily management of hypertension. Almost nearly a twofold increase in 24-hour blood pressure control happened when we were combining both the molecules together. When we are looking at the metrics of morning ambulatory BP or daytime ambulatory blood pressure, nighttime or 24-hour ambulatory, hydrochlorothiazide in combination with telmisartan improved the blood pressure control and maintained a smooth blood pressure profile right through the day. Likewise, the efficacy was maintained in this study also, as it was shown, and it was found to be effective in mild to severe hypertension, advanced state, obesity, chronic kidney disease, diabetes, treatment-resistant hypertension, pretty much the smorgasbord of multiple types of cases that you see in your day-to-day practice. And it was found to be effective and well tolerated in diverse hypertension patients, including those with major cardiovascular risk. So if you are looking at a basic summary, the single pill combination benefits in successful blood pressure management. There are lesser side effects because the dose titration is at a lower dosage, and there is enhanced patient compliance. If you look at the impact on hypertension severity, the results are good. And if you're looking at the effectiveness in high-risk subgroups, the reduction in blood pressure in patients across all the clinical spectrum and scenarios of patients that we see, it is found to be effective. So now let me sully the waters a little and look at, these are my slides, so to basically just give you an input and an idea about what all we are looking at. So this was again a very seminal trial which was done by William Cushman et al. In 2022, and the background was whether CTD is superior to HCPZ for preventing any major adverse cardiovascular events in patients with hypertension, and it was still unclear. huge trial, 13,000 patients plus. So look at the last few lines. So there were no between group differences in the occurrence of any of the components of the primary outcome of cardiovascular outcomes. But the incidence of hypokalemia was higher in the CVD group as compared to hydrochlorothiazide, which means that it was lesser in hydrochlorothiazide. So clinical point is that you need to be careful about electrolyte imbalances with all the diuretics that you're looking at. The propensity was possibly more with CPD. So let me read you through this. Thiazides, they are not differentiating right now, reduce the risk of cardiovascular outcomes, but the choice of which thiazide to use is very controversial. Previous surgeries had suggested chlorothalidone is superior. To come down a little, several observational studies have suggested various effects on cardiovascular outcomes of CPD from no effect to an increased risk with chlorothalidone as compared to hydrochlorothiazide, but with an increased risk of adverse effect, that is electrolyte imbalances and acute kidney injury. This is very, very important. Also, those who were assigned to the chlorothalidone group were more likely to switch to another trial drug during the course of the event. In conclusion, in this last pragmatic trial of thiazides at doses commonly used, that we use 12.5, 25 milligrams, patients who received chlorothalidone did not have a low occurrence of a major cardiovascular outcome or non-cancer related death than patient who received hydrochlorothiazide. The only little bit part was whether the patient was having, or that particular group was having a larger propensity towards acute kidney injury and electrolyte dysbalance. But these are things which evolve over a period of time, and when you are seeing a patient, this is not a one-point kind of a thing. You have to constantly evaluate and monitor. Now this was again a very seminal trial, also known as the diabetic comparison project, the DCP. So the question which was asked was, is there a difference in major MACEs and non-cancer deaths associated with CPD versus hydrochlorothiazide among older patients? Published and by the American College of Cardiology. And the significant answer that it gave was that the findings suggested that CPD may be associated with reduced MACE and non-cancer deaths in patients with prior MI or stroke compared to HCPZ. This still stands, so possibly in that particular subgroup, CPD may be better, but again, these are things which are continuously evolving in terms of clinical practice, and much of your patients have multiple comorbidities, so there is a whole lot of adjustments that you need to do, but this is something which is a clinical standpoint which you need to remember. But it also said that further studies should evaluate this subgroup in further detail or determine whether these results are simply a chance finding or a real. Sufficing to say, it was never done. So things are still hanging, but this is one particular subgroup that you may be considering. So there was a rejoinder by Dr. C. Venkatram to this. Did the design influence the outcome? So he said that, this study being a real world study lacks the robustness of a randomized controlled trial. So are we correct? We don't know. So the principal limitation being unequal exposure of the two diuretics. So maybe longer, or equivalent exposure, the results may have been similar. I leave it at that. Again, a very important publication in the AHA journals, hydrochlorothiazide versus CPD, evidence supporting their interchangeability. Very many people look at these two drugs as interchangeable. And at the level of general practice that we are doing for any patient, आपको टेलमा इसलिए मिला तो टेलमा CP ले लो, that happens. So what they said was that thiazide diuretics are often considered a class of drugs equivalent to thiazide-like diuretics, and I'll come to this nomenclature at the end. And HCTZ, and mind you, these are by luminaries. HCTZ and CTD are often referred to interchangeably. However, it is clear that they are very different compounds. So should one be preferred over the other? Yes. Now both HCTZ and CTD have demonstrated risk reduction in clinical trials. However, the largest trials, including hypertension detection and follow-up, the HDFT, the Mr. Fit trial, the SHEP trial and all that trial primarily used chlorothiazide. Why did they use chlorothiazide? Because it was more readily available, right? And more consistently showed reduction in CV events than the studies that primarily used HCTZ. So although it is possible that these differences are related to the population demographics, it is equally possible that cited differences accounted for the differences in outcome. So they have been the cornerstone of hypertension management. Mind you, look at the wording, they are not differentiating. And although diuretic use has declined for over 20 odd years that it was published, it has begun to increase now, especially after the recommendation of the JNC 7. So, trials sponsored by the NHLPI, use chlorothiazide primarily because of the belief that it might have advantages related to longer duration of action. In addition, intriguing findings on the MRFIX trial suggested that chlorothiazide might confer mortality benefits, but these findings have never been investigated in a prospective study. So we are looking at case control, old evidence. So let's come on to the next one. Comparison and effectiveness of CTD and HCTZ, use meta-analysis. So let me this was again with almost 15,000 odd patients. So let me come to the conclusion. The analysis showed that CTD was possibly superior to HCTZ in controlling both systolic blood pressure and diastolic blood pressure with no significant heterogeneity. However, there was no significant difference between the two groups in the terms of risk of myocardial infarction, stroke, all-cause mortality and hospitalization due to heart failure. So if you are using either of the two drugs long-term, you're basically on the same pedestal. The risk of hypokalemia was reported to be higher with chlorothiazide, as has been said in the other earlier slide also. But further studies are needed to confirm these findings and to investigate the long-term effects of CTD and HCTZ with patients who are hypertensive. Now, these are the Cleveland Clinic recommendations, and this was a very seminal paper. So I'll just quickly take you through the key points. So chlorothiazide has a longer duration of action and a longer half-life. It may be more potent than HCTZ in lowering blood pressure, but we are looking at long-term stats. So in combination, most of these diuretics they do well. But it may also be associated with more metabolic adverse effects such as hypokalemia. No study has conclusively shown either drug to be better in preventing adverse clinical outcomes, and these differences should be considered when making choices about the type diuretic therapy. So in summary, in that paper of Cleveland Clinic, thiazide and thiazide-like diuretics play an important role in managing hypertension, and the 8th Joint National Committee do not recommend either HCTZ or chlorothiazide over the other. The target dose of HCTZ is 25 to 50 milligrams, or chlorothiazide 12.5 to 25 milligrams daily, with low doses to be considered for the elderly, ostensibly obviously for the propensity towards, electrolyte imbalances, potential towards AKI, etc. I'll skip this. This is just a slide showing the differences in pharmacokinetics. So let me study the field a little further. We are looking at, this was again a seminal paper in the American Journal of Hypertension. Thiazide and thiazide-like diuretics, review of all the three culprits put in the same paper. So I'll just go through the basic abstract. The term thiazide is universally understood to refer to diuretics that exert their principal action in the distal tube. The class is heterogeneous and can be further subdivided into compounds containing the benzothiazine ring, the thiazide type, which is hydrochlorothiazide, and those lacking the ring, the thiazide-like, which are chlorothiazide and indapamide. Now, chlorothiazide is an American molecule, indapamide is a European molecule. There are no head-to-head trials, and that will never happen. Right now, there are so many other molecules in the pipeline now being tested. I don't think more trials are going to happen discussing these two when we have talked about so many papers in which you are talking about the interchangeability and equivalence of effects. So, thiazide-like agents are longer acting and constitute the diuretics used in most of the cardiovascular outcome trials, but pragmatic aspects such as lack of availability in convenient formulations may limit their use. Now, regardless of class heterogeneity, thiazides have retained importance in the management of hypertension. Mind you, they are not differentiating here, it's a common word. Patients and augment the efficacy of other classes of antihypertensive when used in combination. Again, going back to one of Professor Mohan's comments, diuretics on their own have no mortality benefits, but in combination, yes, morbidity and mortality benefits. Importantly, a thiazide-based treatment regime lowers cardiovascular events, and the study effect reinforces their place among the recommended first line to treat hypertension. There are very few head-to-head comparisons within the class, but potential differences have been explored indirectly as well as in non-leaking mechanisms and potential theotropic properties until proven otherwise. Mind you, the importance of these differences only remains speculative, and clinicians should assume that cardiovascular events will be low similarly across the agents when equivalent blood pressure control occurs. This basically summarizes the whole talk. So the take-home message for the two molecules concerned: hydrochlorothiazide is an effective first-line antihypertensive therapy for achieving hypertension treatment targets and ensuring patient safety, and in direct comparison, CTD does not have lower rates of major cardiovascular events compared to SCTZ, but has higher risk of hypokalemia, hyponatremia, and potential AKI. Telmisartan is a powerful long-acting ARB that works very well in combination with hydrochlorothiazide, all the more reason because it's a synergistic combination. And the telmisartan SCTZ combination is effective and well received and is a major value among hypertensive patients with increased cardiovascular risk. And many experts consider CTD, as I showed you in the trial and various evidences, CTD and HCTZ as interchangeable. So thank you very much for the question.
Thank you, Dr. Singh. You can come here. We'll have a question answer session, and I'm sure you will have some interesting questions. Can I request Chandruveer or one of the team from Chandruveer, please, or one of your boys in the territory manager who can take the mic and to the audience. I'm sure so we have some very good clinicians here, and they will have some interesting questions. Dr. Chakravarti sir, you must be dealing with pediatric hypertension, childhood hypertension. So what according to you is the role of diabetics in pediatric hypertension?
I think that's the first line of action in pediatric hypertension. Though we do not really see very many cases of hypertension in pediatric age, except the kids who are very obese or nephrotic. In nephrotics, we see a couple of cases who are on the diabetes, on the hypertension side. Otherwise, it is a familial hypertension. Then we see cases. Not a routine, primary hypertension is not a normal cause of kids. But thiazide remains the first glucoside, and all these things remain the first line of action in our age group. Thank you so much.
Dr. Luthia sir, can you give the mic to Dr. Luthia?
So you have discussed only thyroid and thyroid-like diabetes, but you have not discussed loop diabetes like furosemide and furosemide, and the relative risk of hyperuricemia in all the five. And in case of hyperuricemia, do they discontinue the drug or add glucoside?
Sir, you have a good question, but the relevance I must say, sir, loop diuretics we are usually restricting to heart failure treatment. And here we are talking about the role of diuretics in hypertension treatment. So when it comes to treating hypertension, either it is hydrochlorothiazide or chlorothalidone. We are using loop diuretics in cases where heart failure is associated with hypertension. What is the question, sir?
The discussion is also regarding hyperuricemia with any of these diuretics.
Yes, sir. All the diuretics, especially the loop diuretics, are likely to cause hyperuricemia. As
which one is more likely? That's
Sir, do you have any insight? I don't have any insight. Do you have any?
Indapamide has least propensity.
Yes, sir.
So that's not a loop
Do we
diuretic.
discontinue?
But it is not a loop diuretic.
No, it is highlight diuretic, highlight like diuretic. And do we discontinue the?
Sir, your question was which loop diuretic has the highest propensity for hyperuricemia? Which diuretic?
Yes.
Which diuretic? So loop diuretics are more likely to cause hyperuricemia as compared to thiazide-like or thiazide-type diuretics. That is one thing. That is one thing. Second thing is the topic today is role of diuretics in the management of hypertension. We are not using those diuretics for the longer duration of treatment. Okay, it is a different thing if you are using them in a crisis, like left ventricular failure associated with hypertension, left ventricular failure associated with myocardial infarction, etc., etc. So please,
Do we discontinue the diuretic in case of hyperuricemia or hyperuricemia?
sir, I don't have an answer to that. If you have an answer to that,
I am asking the speaker.
Yeah, maybe. Sir said very correctly. See, the point is, if you have a volume overload condition, whether it is heart failure or you are looking at kidney failure status with volume overload or even hepatic failure, you have to give a loop diuretic, right? And sir, you have to monitor it consistently. If the volume overload stays, then you have to give a loop diuretic and manage the hyperuricemia accordingly. With diet or with some medication like Xyluric or Febuxostat. But the crisis or the increase in the hyperuricemia is not to the tune of 12, 13, 14. It just goes up from the routine 7 that we are talking about. It may be going up to 9 or something, which is manageable. And in every clinical situation, you have to look at the larger clinical picture. For example, I'll just give you an oblique example. If an SGLT2 inhibitor is being given to a certain patient, and if that person has a UTI or a genital infection, you still try to, after stopping, try to reinitiate because the humongous benefits of SGLT2 inhibitors far outweigh the chota-mota UTI or a genital. Likewise, if you are having a volume overload condition, you have to give a loop diuretic. Maybe you might change the diuretic from furosemide to torsemide and see. Maybe give a larger dose, then withdraw a little and see. At the same time, constantly evaluate clinically. There is no absolute answer to this, but it's constant monitoring, and then you see whatever benefits the patient in the clinical scenario.
What percentage?
just a minute, Dr. Luthria sir, just a minute, sir, just let me answer. Sir, hyperuricemia is an issue, and he has beautifully summarized that it's a drug which should usually be given in combination. Choose a better combination. Choose losartan instead of telmisartan. Losartan is an ARB which is known to cause decreased levels of uric acid. So you might also change the combination. If hyperuricemia becomes an issue and you need to continue it for a longer time. However, loop diuretics in today's practice, and sir, you are a wonderful practitioner, you know how frequently you use loop diuretics. Hardly any time, sir. And you use thiazide or thiazide-type diuretics abundantly now, especially after the re-emergence. I think even Glenmark people should thank chlorothiazide for actually bringing the diuretics again into relevance. So that is one credit, but choose a wiser combination which is more likely to reduce uric acid levels, and that combination is losartan with a loop diuretic. I think Dr. Vajirana sir is nodding his head in approval. Dr. Sengupta.
Cardiovascular benefit you have said, but in diabetics, which diabetics would you prefer?
In diabetics, which diuretic you prefer? Any of them.
Any of them is same.
It's a question of constant evaluation and monitoring which is there. It's not just a monitoring.
Sorry? Is the hydrochlorothiazide affect the diabetic?
Good question. Can I answer it, Dr. Alright. So it is the same question as which statin would you like to use? So what did Jupiter tell us? Jupiter trial on rosuvastatin told us that although there was a remarkable effect of statins on reducing cardiovascular mortality and morbidity, but there was a slightly increased incidence of elevated impaired glucose tolerance. But what is the benefit risk ratio? Heavily in favor of using the statins. Why are you using a hydrochlorothiazide? You are using hydrochlorothiazide because you want to have a better BP control. And please understand that whether it is in combination with diabetes or stand alone, the rule of halves apply to hypertension. Only half of the people ever get diagnosed. Only half of those who ever get diagnosed actually get to the table of treatment. Those who are getting treatment, only half will continue to take treatment, and of those who continue to take treatment, only half of those will have a good control. So where do we land up? 6.25% of the initial people who actually had hypertension. Therefore, what is the benefit risk ratio of controlling blood pressure? Heavily in favor of controlling blood pressure rather than bothering about the age-old issue of slight impaired glucose tolerance. That happens with beta blockers also. But are you not using beta blockers? Beta blockers are known to cause impotence. But are you not using beta blockers in a post-MI scenario, in a post-ACS scenario to decrease and to achieve secondary prevention? We are using it. The entire game in the pharma is to understand the benefit risk ratio. If you are using a hydrochlorothiazide, is the ratio in favor of using it or not in favor of using it? So that is the answer. Sir,
How is it useful in this one?
let him add, sir. Let him add.
Just a minor addition. See, all these trials were carried out under very controlled conditions, right? And none of them had Indian patients. If we are talking about that kind of a scenario we have. So, CKD had lesser propensity for developing diabetes compared to SCTZ, which meant that it had lesser propensity, but it still had. Now, which that patient is, we don't know. So you can maybe use another drug at the same time, you can think about it in the clinical scenario. SCTZ had more, but in your particular patient profile, it might even be less. We don't know. We are just talking about stats out here. So when you are translating it into real world evidence, you have to look at the clinical scenario in a holistic manner and then see. You are always having an option of alternatives.
Also,
wonderfully answered.
Just a minute. Just a minute.
Wonderfully answered.
Also, we have to understand, and Master Dr. Tulsi will agree with it, that there is an real issue of hypokalemia in our country. Even in September, we had a camp today in Dr. Sushil's Almar's facility in East of Kailash, and one young boy, 25-year-old, he collapsed because of the humidity. So, when we are using diuretics in India, starting from the first week of April till the last week of October, there is a lot of humidity and we have to be very, very vigilant about the issue of hypokalemia. And Dr. S Sengupta has beautifully brought out with various trials that although there might be slight benefit as far as the cardiovascular outcomes are concerned, and also in some specific situations of post-MI and post-stroke, CTD versus hydrochlorothiazide, in the longer scheme of things, you have to use a diuretic which is less likely to cause hypokalemia, and that diuretic is hydrochlorothiazide, not chlorthalidone. Alright? Sir, your question.
How it is used in diabetes insipidus?
Diabetes insipidus.
How it is
That is not the topic, sir, today. That is not the topic.
Sir, another thing is it is
Sir, let us restrict ourselves to the use of diuretics in hypertension.
now it is also sulfur molecule sulfuride type. So there are possibilities of sulfuride. How many?
Question, sir?
It is a sulfur molecule sulfuride type.
So allergy towards the sulfur.
Sulfur.
Yeah.
Even though
Very rare.
Sir, it can happen. It can happen with any molecule. Steven Johnson is known to be associated, but it's a very rare occurrence. And if your patient gives history of Steven Johnson previously with sulfur molecules, kindly avoid it. Kindly avoid it. I would our patron, Dr. S. Mathur sir, who has as much of experience with this molecule as my age is. Sir, your comment, sir, please.
Thank you, Sushil. Dr. Sengupta, the wonderful common use of diabetes and hypertension, which is a very common issue in all cases in our daily practice. In hypertension, if it is not controlled, as widely brought out, it's very poorly controlled across the world. Now, objective of using diuretic early in the practice is also very important. We have been using all our life, using diuretic along with the either calcium channel blocker or Reassurance or SV. So I think it is a very good combination as you brought up. Reassurance with hydrochlorothiazide. It does control a good hypertension. But bottom line is we have to monitor them very periodically. If the blood pressure is not controlled, we need to change our medication plan. There are many other drugs available in the armament which can be added or this can be changed. So chlorothiazide with hydrochlorothiazide and you rightly brought out comparatively, the both are equal. There is hardly any difference in use of any of them. Depending on the choice of the physician who is using them, whichever he wants to use it. But yes, he has to monitor and observe the hyperkalemia and general hypertension. I think well said, Dr. Sengupta. Sushil, you done.
Also, sir, it's very important to understand that every physician has a comfort level with a particular molecule, which he has more experience with and will continue to use it until there is some specific contraindication or clinical situation in which he is, obligated to change.
I agree with you.
Then you will take it, sir.
Individual physician choice. Thank you. Thank you, sir.
Also, another thing, and I'm sure Dr. Tulsi would have that in mind. But before you ask that question, please remember one thing about diuretics for everyone's important and knowledge. Diuretics are prone to tachyphylaxis. The more you use diuretics, the more you get used to that particular dose of diuretic. So if you are a kind of tolerance. So if you are being controlled on 12.5 milligram of hydrochlorothiazide this year, after 5 years, if there is a loss of blood pressure control, kindly consider increasing the dose of diuretic and you need to monitor the electrolytes. That is very important. You need to do that more often with chlorothalidone than with hydrochlorothiazide. Dr. Jitendra Saxena has a question.
Sir, as you said, this talk today is on the high-end group of diuretics and related to hypertension. Because we are not discussing the other agenda, but in several cases of hypertension, and I've heard several speakers say that in case you are not able to control your blood pressure with 3 drugs, 4 drugs, try spironolactone. That works well.
That's right.
So we are talking about a diuretic. I'm not talking about heart failure, which can be used in hypertension. Yes. This is not a thiazide or a diuretic, but a potassium spironolactone. So in context of the lecture today, role of spironolactone in controlling hypertension.
So, thank you very much. You are talking about the syndrome of resistant hypertension, and I will invite all of you to join the involved meet on Sunday where I will be speaking on this particular topic only. So, as you rightly said, we are looking at hyperaldosteronism states which are there, which are often underdiagnosed. So the fourth drug that has to be used is spironolactone, which obviously potentiates all the therapy after you have actually optimized the drug therapy or the patient already is on. So what you are saying is absolutely fine clinically. Spironolactone is the way to go as the fourth in this. And if the patient is not responding or is controlled on more than 5 drugs, that particular state is known as refractory hypertension. So resistant hypertension, ideally you look at the ACD combination, ASAPs, calcium channel blocker and a diuretic. If the patient is not controlled, you call it a case of resistant hypertension. Then you obviously have to see whether you look at pseudo-resistant hypertension and other formats. But the fourth drug to be initiated after you have diagnosed resistant hypertension is spironolactone. That's absolutely fine. Very well taken.
So another thing, let me just add, Dr. Jitendra. One of the criticisms of using diuretics in hypertension treatment has been that they have not been associated with changing the mortality benefits or clinical endpoints. It is both with hydrochlorothiazide and with chlorothalidone. Now, please understand the difference between using diuretics for heart failure treatment and for using standalone hypertension. What is the benefit? As Dr. Sengupta beautifully said, and he is going to deliver a lecture in Wall, which is going to be on 21st of September. And I invite all of you for that meeting being organized by Dr. Ashok Seth sir, and he will be one of the speakers. Please understand this. Spironolactone or spironolactone-like drugs, mineral receptor antagonists, they were associated with 35% less mortality in the heart failure trials, which is a wonderful result. So there are two different things. Use of MRAs in heart failure treatment and use of MRAs in hypertension treatment. Hypertension treatment, they are reserved for the last. Okay, when you have diagnosed resistant hypertension and you have still not, and you have also used a diuretic. And that is how we come to these MRAs of using these medications. What's your question?
You just said you also use diuretic and then you have. So suppose I'm already using thiazide diuretic in my, can I add, like we do add furosemide and spironolactone in Fusilac, can we add thiazide and spironolactone kind of combination which will take care of the hypertension?
You can do that, but please understand that you are then walking a very thin road, because you have to tread very carefully with electrolytes. You have to be careful with that. There is no harm and there are no guidelines that you cannot use the both. You can use both, but how you use it, you have to be very careful.
So, two things that you have to see when you are using spironolactone is that the eGFR should not be less than 30, and have a look at the potassium, because spironolactone builds up the potassium to higher states. So if it is already more than 4.5, spironolactone may not be a very prudent choice, but if you have no other alternative, you go ahead and use, especially a primary hyperaldosteronism, which is Cmes syndrome. But obviously keep a very leading view on that and constantly monitor. So that's important. Like I said, in every clinical scenario, you have to monitor, take it one step at a time and then go forward.
I think you have to understand few things about treating hypertension, and those things are, one is the systolic hypertension. So there was a question whether systolic hypertension, a blood pressure of 180, and when I was doing my MD in 86, we were said, no, don't worry about systolic hypertension, only bother about diastolic hypertension. And then it took a 180 degrees turn, 360 degrees turn after systolic hypertension in elderly program. They said, no, systolic hypertension is very important. And what were the drugs which were supposed to be very useful for the treatment of systolic hypertension? Calcium channel blockers and diuretics. What was the additional benefit of using diuretics with calcium channel blockers? That was, which Dr. Sengupta said, ambulatory blood pressure monitoring. Blood pressure should usually dip in the morning. There is a group which is called non-dippers, and these non-dippers, this phenomena is associated with early morning MI and strokes. Okay, so when you add a diuretic to the whole plan of things, these two things, the mortality comes down. Right, and this is what was seen when indapamide was added to in the advanced trial. When indapamide got included, okay, with pyrindaprin, right? So there was a decreased cardiovascular mortality. What was the additional thing? Indapamide. With what? With this ARB, right? So the addition of diuretic and the proper diuretic can achieve wonderful results, but you should know where to use it. Dr. Tulsi will now have the final say. He will have some questions which only he will be able to answer. So please.
So let me begin by saying, those was masterly talk by Dr. Sengupta. Not to forget the celebration with our master, Dr. Chauhan. Wonderfully decorated. So I have very little to say after those masterly talk and his contractions and all that. So, but answer Dr. N.K. Gupta's question, as Dr. Sengupta very vividly and correctly said that all diuretics would probably cause some amount of metabolic abnormalities. When I said metabolic abnormalities would be incidence of diabetes, high uric acid, and getting pains and lipids as well. So whether it is a loop diuretic or a thiazide diuretic or a thiazide diuretic, all will cause. The mechanism is still ambiguous. Why does it cause? We don't know. You have an answer to that? Okay. So let me dwell a little about the recent ACCHA published in JAMA Cardiology, December 2024. 3 findings. As you already said, just to refresh, the CTD is not superior to SCTZ in preventing kidney disease progression and decreasing CV events, meaning both are almost same. But as Dr. Chauhan correctly said, CTD would cause more hypokalemia as compared to the SCTZ, but the percentage is just 2%. Dr. Thirdly was both medications are reasonable in the treatment of hypertension. You could use either of the two, not to forget nepamide as well. But as we know, chlorothiazide and nepamide have a longer duration of action. Probably, to my mind, would be more effective being a longer duration of action as compared to hydrochlorothiazide. Now, let's talk a little about the SPIN trial. And the ACCA recently said, maintain BP around 120 by 80. With around 120 by 80 meaning maybe 130 by 80 as well. So the SPIN trial, I'm a big fan of the SPIN trial, I don't know about you too. 28% reduction in all-cause mortality, 25% reductions in cardiovascular events and renal progression. So lower the blood pressure, the better is the outcomes. So what do you aim at, Dr. Chauhan, Dr. Sengupta? What in your set of patients, what do you aim? Blood pressure around 120/80?
Yes.
Lower the better?
Yes, sir.
Not to forget the 3 things which would occur: hypertension, electrolyte abnormalities, and AKI.
So 120/80 is a good blood pressure, but please understand if there is associated CKD, especially in diabetics, we would like to have a little lower blood pressure and lower the better in
Lower than
CKD.
120/80?
Lower the better in CKD.
Absolutely.
Right? But
To decrease the progression.
110/70 maybe is okay, but don't get it below 100.
What about in elderly hypertension?
Sir, in elderly hypertension,
You could be lenient.
please, you be a little lenient. Do not be very aggressive, because sudden lowering can actually precipitate a stroke rather than solving the problem.
Thank you, sir.
Even in CKD situation,
Sir.
Yes,
yeah,
sir.
yeah. For circulation. Yeah. Even in CKD, you should not be letting it down below a point, because that would affect the apparent arterial circulation. So the GFR needs to be monitored constantly so that you have adequate renal perfusion so as to delay the progression of the CKD.
I think our product manager from Cmes, please, there is some new information on telmisartan. Can you give it to us, sir, please? There is a breaking news. Just give us 1 minute, please. And it is not Pakistan playing in India.
It's not, I'm not even
Sir, please.
So only one thing I would like to add, that the recent 2025 ACC-AHA guidelines also recommends that there is one type of category that is elevated hypertension as well. So when in elevated hypertension, in CKD or in diabetic patients also, as sir said that it should be maintained below 120, that is 110 is essential. And ACC-AHA guidelines now recommend 2024 the 2025 guidelines also recommend thiazide type.
Recently,
Yes,
just a
sir.
month back, yes.
Yes, sir. Recently, the
Yes,
month of
August.
August,
Yes.
then it recommends thiazide type diuretics and ARB and CCP as well as first line therapy. That's the thing I would like to. Thank you.
Right. Thank you very much. I would request Mr. Praveen Agarwal to give a vote of thanks to all of you, please.
Respected Dr.